Good afternoon. I'm Brianna Bowling, and I am the chairperson of the University of Maryland Charles Regional Medical Center. November is Diabetes Awareness Month, and today's webinar is meant to examine a health issue that is of critical importance to many Charles County families. And it's also to provide you with resources, information, and education about this life-altering disease. We have a few housekeeping items before we get started. If you experience any technical difficulties, you can post your issue in the Q&A panel and we will get an answer to you. This event is being recorded, and so you can view it later as well. For optimal viewing, you can change your view by going to the top right-hand corner of your screen, hovering over the small circle, and choose side-by-side view rather than the video strip view. That's the one right in the middle. This is an interactive webinar, and we want your participation. We encourage you to submit written questions at any time during the presentation in the Q&A panel. That is in the lower right-hand side of your screen. We will address questions during the Q&A session at the end, but don't hesitate to ask a question at any time. The only dumb question is the one you didn't ask and you're still wondering at the end of the webinar. And I'm here to learn right alongside you. According to the latest available data, approximately 10.8% of Charles County adults report having diabetes. It is the fifth most common cause of death in Charles County. And in addition, diabetes deaths are more common among local residents than they are in the state of Maryland as a whole. And although no two diabetes diagnoses are exactly the same, education and support are a big part of improving patient outcomes. So let's get started. Mary Hanna is our first guest, and she's a registered nurse. She has a master's of public health. She's a certified diabetes educator. She is the manager of population health management at CRMC. She has 20 years of hospital experience, and she presently oversees programs for transitional care, diabetes education, and inpatient palliative care at Charles Regional. In 2016, she joined the staff at Charles Regional to develop and pioneer the Center for Diabetes Education. Thanks, Mary. And to date, the center has provided diabetes education to over 1,000 people. So welcome, Mary.
Thank you, Brianna. I'm delighted to be part of this discussion about diabetes. Our hospital and my team do fantastic work to help educate and empower patients with diabetes. Let me start by saying that diabetes is really a personal topic to me. Like many, there's not many people that you would meet that don't either have a family member or someone close to them that has diabetes because it's so common. For me, many of the men that I love dearly in my life are plagued by diabetes, starting with my pop, my grandfather. He had diabetes from a young age, and it actually robbed him of his vision. He'd had multiple strokes by the time he passed away. My father has been diagnosed with type 2 diabetes for several decades now, and he still struggles. He would tell you he has cravings for sugar that are really hard to overcome. And then more recently, my husband was diagnosed with prediabetes, and he and I are trying to make some lifestyle changes and get ahead of that diagnosis so he does not get the diagnosis of diabetes in the future. Also, so many of the patients I've encountered over the years as a bedside care provider were ravaged by this disease. They often faced risk of losing life or their limbs. It is a silent killer, similar to hypertension, and people may have it for years before they're ever diagnosed. So let's talk more about diabetes.
Oh, good. And thanks for giving us the background of why it's so important to you beyond just wanting to take care of our population health. One of the reasons that we're doing this today is because November is Diabetes Awareness Month. So can you go over some of what are the risk factors for diabetes?
Yes, that's a great question because we want people watching for these risk factors and for the signs and symptoms. It's so important to know if you're at risk for diabetes and to talk to your primary care provider if you believe you may have it. So let's talk about some of those risk factors. Some of them are preventable. That means you can still change them. And some of them are non-preventable, which means you're likely born with it and you can't do anything to change it, but you should still be aware of it. So your age, if you're 45 years or older, you're at higher risk. Certain races, African American, Hispanic, Latino, American Indian, Asian American, or Pacific Islander are all at higher risk. So if you have a parent like me and my father, or a sibling with diabetes, if you're overweight or obese, so that would be a BMI of 23 or greater. If you're physically inactive, that's another one of those preventable ones. If you have high blood pressure or take medication to control your blood pressure. And lastly, if you had diabetes while you were pregnant, which is called gestational diabetes, you are at higher risk of developing diabetes later.
So if I'm watching this now and I'm a little worried that I might have diabetes, can you go over some of the signs and the symptoms that someone might have if they have diabetes?
Yes, I'm happy to touch on them, but let me first explain that there's basically 3 types of diabetes. I just mentioned gestational, that'd be while you're pregnant, but really I want to focus in on type 1 and type 2 diabetes. Type 1 would mean your pancreas, a little organ in your body that sits below your stomach, has stopped producing any insulin. Insulin is like a key. It unlocks your cell and lets your blood sugar move from your bloodstream into the cells where it's needed for energy. So for that type 1, that's about 10% of the population diagnosed has type 1 and usually diagnosed pretty young in life, and it's a very fast onset of those signs and symptoms. Type 2, which we'll focus on more today, is about 90% of the patients diagnosed with diabetes have type 2. It's more slow onset of symptoms, and I actually read somewhere some people can have those symptoms up to about 10 years before they even know they have the condition. So just imagine all the damage done by that point. So let's talk about the signs and symptoms. Type 2 would be more slow onset usually of these things. But if you're urinating often, if you're feeling very thirsty, you're drinking and just can't seem to satisfy your thirst. Feeling very hungry, that would mean after you even had a meal that you continue to feel hungry or perhaps crave sugar like I mentioned with my dad. Extreme fatigue, just feeling tired all the time. Blurry vision. Cuts or open wounds that are just very slow to heal. Having weight loss, really sudden weight loss, that's more specific to type 1. And then tingling, pain, numbness in your hands and feet, that's more specific to type 2. So any of those symptoms or combination thereof, definitely be talking to your primary care provider and don't wait till it's at the point of you're ending up in the emergency room for that diagnosis.
Wow, I didn't know some of those symptoms, so that's really good information. So let's say I go to my primary care physician, I've come to him and I'm like, hey, I have some of these signs and symptoms of diabetes, and he's going to confirm that I have it. How do they actually test to make sure that I have diabetes or to confirm it?
So that's a great place to be because they need to do a fasting plasma glucose, which would be done through talking to your doctor. Fasting means that someone's not eaten or drank anything for at least 8 hours other than water. They would do that fasting plasma glucose by a quick blood draw, and then your results from that is what would tell you whether you have diabetes. So a normal range would be the fasting plasma glucose, say that 3 times fast, 100 or less. Pre-diabetes would be 100 to 125, and then diabetes would be if you're 126 or greater. They can also do a random plasma glucose level. If, say, you're having a bunch of symptoms, you go to your doctor, but it's afternoon and you've already eaten, they can go ahead and just draw a random one. And if that's 200 or greater, you're going to be diagnosed with diabetes.
Okay. And I've heard the term pre-diabetes. What exactly is that?
So before people develop type 2 diabetes, they almost always have something called pre-diabetes. That's when your blood sugar starts to become elevated. Like I mentioned, that fasting blood sugar that they can test at your doctor. If it falls between 100 and 125, you have pre-diabetes. This is a condition that puts you at higher risk of developing type 2 diabetes and having cardiovascular disease. And believe it or not, 1 in 3 Americans have pre-diabetes.
Wow.
But unfortunately, many of them do not know it. About 90% do not know they have it.
That's crazy. 1 in 3 is a huge number. So let's assume that somebody actually does discover they actually have pre-diabetes. What should they do at that point?
Well, definitely don't panic because that is
okay. Think you're said.
Take it as a warning sign. so many of us don't get warning signs, and all of a sudden we find out we have this condition we didn't even know was coming upon us. So the good thing about hearing the word pre-diabetes is that you still have some time to intervene. If people jump into action and they make some lifestyle changes, they learn to eat differently, add activity, maybe lose some weight. If you can lose 7% of your body weight, so say you're 200 pounds, if you could drop 15 pounds, you'll be able to greatly decrease your risk of going into diabetes by 58% just by losing that 15 pounds. So it's definitely something that we can do when we set our mind to it to avoid that actual diagnosis of diabetes. There's some great classes out there you can jump into. I'll start with the one at Charles County Department of Health because I have personal experience of attending that with my husband. It's called DPP, Diabetes Prevention Program. It's a year-long program and it's accredited by the CDC. And they teach you how to go about doing those lifestyle changes, but it's very slow and gradual. You're part of meetings, you learn education, you learn all about your food choices you should be making, but they gradually ease you into it. And it's a great program. So also here at our hospital, University of Maryland, Charles Regional Medical Center, we have a diabetes self-management and education program. And we can see people with prediabetes as well, depending on their insurance and if their insurance will cover for them to come to our program here. So there's a lot of options to help you, to coach you, to get on the right track. So take it as a warning and do something about it is my best advice.
Yeah, education is key. There's no doubt about that. So you talked about somebody who has prediabetes should get the diabetes education. Is there anyone else who should get the diabetes education?
Absolutely. So if they have type 1, type 2, gestational, they should all be thinking about education. And there's basically like 4 key times to think about coming in for education to one of the programs like I mentioned. That would be the diabetes self-management program. So when they're first diagnosed, when you're first diagnosed with any condition, the first thing you're going to ask, hopefully, is what can I do to take care of this? And that's what we're going to be explaining when you come in for education. Or if you've had some kind of new complication due to your diabetes, that's a good time to come back in for education. Annually is another time. Sometimes life happens, right? This time, I don't even want to mention the word because it's nice to talk about diabetes and not the C word for a change, like it's been on all over our minds. But this year it's been tough and a lot happens, and sometimes we just need someone helping to keep us on track. So coming in annually can help do that with that nurse educator you would see. And then lastly, when you have a transition in care that occurs, like starting an injectable medication such as insulin for your diabetes, that would be a time to consider coming in for education as well. To come to our program here at the hospital, which is located on our first floor, they would need an order from their doctor. So they should always be talking to their doctor about education, support groups that are available, where can you get help? Once they come into the program, we actually do 10 full hours of education the very first time they come in. It starts with a one-on-one meeting with our nurse educator, where they just basically ask your story. What led to where you are now? What do you like to eat? And believe it or not, they're not the food police. They're not going to be telling you you can't have that and only eat this much of that. They're going to work with you with the things you like, but try to help you to ease into some changes that will be healthier for you in the future. They're basically like coaches, and that's what they want to do. So after that first meeting, when they work with you, they learn about your likes and dislikes. They're going to have you come back in usually for group classes, which would be every other week, so it spans about 2 months that you come in for this education. But so often our patients, after they've been in for the education, find their blood sugars are so much improved. Their A1C level, which is another thing we watch, which gives you a 3-month view of where you've been averaging for your blood sugars, that's hemoglobin A1C. They are so much better, even beyond the national standards. Usually the patients coming to our program have greatly improved. They feel more comfortable about knowing what to eat. That's always their question when they first come in. What can I eat? What should I be drinking? And so they have that time to learn exactly what they should be choosing, what foods have carbohydrates that are going to be higher and produce sugar when they get to their stomach. They also learn how to make choices out in restaurants, because the fact is we don't always eat at home. Sometimes we're on the go. Sometimes we want to eat out at a restaurant for celebrating something, so they need to know what to choose. Many people often end up losing weight while they're in our program, and they just learn things to do to help themselves prevent complications from diabetes?
That's great. I mean, it sounds like the Diabetes Education Center is like such a fabulous resource for our community. So, and honestly, I didn't know much about it until we just sat down today. So I'm really grateful to learn about it and know that it even exists in our community. So thank you very much, Mary.
You're welcome.
So that's really, really helpful to know all those things. If you could stick around to the end, again, if you want to have any questions at all for Mary or for Dr. Cadieux, post them in the Q&A, and we're going to answer them at the end of this webinar. But you can post the questions anytime, and Mary's going to stick around to the end to answer those questions. So thank you very much, Mary.
Thank you. Happy to do so.
So before we chat with Dr. Cadieux, I do want to show a brief video about CRMC's Diabetes Education Center. So if we could roll that, that would be great.
Are you living with diabetes? Is someone you love? 30 million Americans are. Many more are at high risk, and many others have it and don't know it. November is Diabetes Awareness Month, and we want you to know our community hospital has the resources you need, from diabetes educators to wound care specialists. We're here to help you with referrals, appointments, and classes to help you manage your diabetes or prevent it. Visit umcharlesregional.org/diabetes today to find out what we can do for you.
Well, thank you very much. And there is, I know there was some contact information posted at the end of that video, but also at the end of this webinar, there's going to be the contact information for the Diabetes Education Center and for the hospital will also be posted. So next up, we have Dr. Cadieux. And so in the short term, diabetes is not a debilitating condition, which means that people aren't as likely to seek expert care immediately. But if it's left untreated, diabetes can have long-term and sometimes very debilitating consequences. So here to discuss that is Dr. Cadieux, who is the foot and ankle doctor with the Center for Wound Healing at Charles Regional. Dr. Cadieux specializes in treating foot and ankle ailments, and in particular, those associated with diabetes patients. She focuses on educating and communicating with patients on what they should be doing at home to better their outcome. She's currently a member of the American Board of Foot and Ankle Surgery and the Maryland Podiatric Medical Association. She's also been nominated as one of La Plata's top doctors. So thank you, and really glad to have you here today.
Sure, thanks. I'm glad to be here, and I'm glad to be getting the awareness out about diabetes. It is a public health crisis here in the United States and worldwide. To start with the first question, if left untreated, what can diabetes affect our lower extremity? To put it simply, when your sugar is high or higher than the recommended limit, it does cause what's known as neuropathy, which is nerve damage. And what that means is it's that the ordinarily issues like blisters or things that we step on or pressure sores on our feet that you would feel a pain response to and would notice go unnoticed. So unfortunately, that leads to progressing of the wound, which can lead to infection. And typically, in uncontrolled diabetes, it's not noticed until it's infected and the person is sick and sometimes in the hospital, requiring things like IV antibiotics. And then, the worst case scenarios, things like amputation. So the goal, for all of us is, of course, to keep our diabetes as controlled as possible to limit those things.
So you said that part of the problem is, one, that it doesn't heal as well, but also you're saying also that they may not even notice that there's a problem because they don't actually feel the pain. Is that, if I understood that correctly?
Exactly right.
I did not know that. That's good to know.
Yeah, the neuropathy, the nerve damage, it can be like nerve death is what I tell patients. And it means that you feel really nothing on the bottom of your feet. And so often in the hospital, people come in with large wounds in their feet that they didn't really know were there or only knew were there for a few days or a week. And these things can develop fast, but it's likely that they were developing for several days or weeks without being noticed. So it's something that I speak to my patients a lot, things like looking at the bottom of your feet all the time, wearing things like white socks so that if there's drainage or problems, you can see it on your socks, and, just keeping not only knowledge of it, but also just looking at your feet all the time, every day.
Okay. I think that's great advice for anybody, whether they have diabetes or they think they do. So when they first come to visit you, what can they expect? What's the thing that a new patient is going to expect when they first come to see you?
Sure. So it depends on the patient. I like to find out like where they're starting from. Sometimes when I first see them in the wound care center, it's really about discussing how to get their diabetes under better control, and why it's needed in order to help heal their wounds. In other instances, I have a lot of patients that come see me as soon as they get a diabetes diagnosis, and it's really about educating them. And their diabetes may be well controlled at that time, but, telling them the effects of the diabetes and how to keep your sugar at a manageable level and really what the goal levels are for that person. And those vary from person to person.
Okay. All right. So they do vary. That's what I'm just getting ready to ask you. What were those goals? But you answered it already.
Yeah.
So you mentioned at the beginning, like wearing white socks and looking at your feet every day. Are there some other things that you tell your patients that they can do to help take care of their feet, whether they have diabetes or not?
Yeah. So what I guess what I tell them is every day, like after they shower, for example, it should just be made a habit to clean and dry your feet really well, because we want our skin to never be like not too wet, not too dry. Our skin is its strongest when it's sort of right in the middle, like how our hands are. And then after they dry their feet, they should look at them. And if they're not able to, then their partner or whoever is in their house that is assisting them can also be that person. And then always wearing white socks is important. And then always wearing shoes, even in the house, is important. And
why is that?
So sometimes people step on things in the house, or people, may not leave the house that often, but they still really need the offloading, whether they're in or out of the house. There's shoes that can be made for their feet that will offload these like high pressure areas that can become problematic. So I do sometimes recommend having like 2 pairs of shoes, because some people like house shoes and some people like, and that's fine, but I don't really recommend them ever to be barefoot. And that's in or out of the house. Okay.
All right. I'm probably not your best patient.
Yeah.
I'm going to try to learn some things today as well. So
we can work on it.
Well, I appreciate the advice too. I said I was going to learn right alongside, and I am. So let's say that somebody can't manage their self-care. They're not be able to get some of the things done that you're asking them to do. At what point should they come into the office? I mean, when is it that they should actually make an appointment to come see you?
Mm-hmm. So I always welcome patients to come as soon as they are told they have diabetes, because it's an overwhelming diagnosis and it requires a lot of education from all of the different disciplinary teams. And so they can come in as soon as they're told they have diabetes. Sometimes, they're doing well on their own. So the next level would be is if the patient does have numbness or tingling in their feet, that's like early signs of neuropathy. So they should definitely come in then. If their hemoglobin A1C is really anything higher than 8, I think that they should come in then. The goal is about 7, and when they're about 7, they're far less likely to have really any of the complications that we see with diabetes, such as the foot sores or the neuropathy. But yeah, I mean, as soon as their primary care is starting them on medicine for diabetes, they're welcome to start at that moment in time.
Should they come in even, you said as soon as they're diagnosed with diabetes, but should they come in even if they're not having any problems at all with their feet?
I would say at least one time, and, if there's any questions, they can be discussed, and if maybe at that point they don't really have any questions or they don't need anything, and then it's just like an annual checkup. The goal is to only see patients here and there, but just some, preventative care is like the best care for my field, that's for sure. So.
No, and that's what it sounds like, that if you can take care of it before it happens and you have the education to prevent it, then it's going to be a lot easier down the road. Is that accurate?
Yeah.
Great. So the other issue is just, we're in the midst of COVID right now, and there's so many people who are putting off preventative care, just like what you suggested. They're not making doctor's appointments. So what if somebody's putting off their care to come see you, whether they've just got diagnosed with diabetes, whether they're having problems with their feet, whatever the issue is, if they put off that care, what are the ramifications with someone with diabetes? And especially if they're experiencing complications, what could happen?
I will say, like, during this COVID period, I've seen far more patients in the hospital who are having their first like severe complication, meaning they had a wound that wasn't being evaluated or wasn't being treated, and now it's infected. And they have fevers and chills. They have, what we call a sepsis. And a lot of the times they require surgical removal of the infection, which can be amputation. So, I know our office and I know many of the offices in the area are taking all of the recommended safety measures. So I would recommend keeping your doctor's appointments as best that you can, because the consequences are, that the infection or problem is kind of severe, and we wish we would have seen each other sooner.
Okay. And then you definitely feel that as people come into the hospital or into your office, that they are safe, that their precautions have been taken.
Definitely.
I think that's really important for people to know that it's probably one of the safest places we can go right now.
Yeah.
We're definitely doing a great job there. So I appreciate all those answers. We are going to move into the Q&A session. I think that we're going to have some questions for you. So if you could stick around just for a few more minutes to answer those questions. And actually, this first question could be very easily addressed to either one of you, so you can decide who wants to answer this. But I think at some point, an endocrinologist, that comes up. I don't know what that is. Can you tell me what is an endocrinologist and when should I see them and what does that have to do with diabetes?
Dr. Cadiuex, you want me to start and you can elaborate?
Sure. Go ahead.
Sure. So endocrinologists are specialists of the endocrine system. So they help patients with diseases that involve glands, hormones, or their metabolism. You should see an endocrinologist if you're having difficulty managing your blood sugar levels. And usually you'll do this after having a discussion with your primary care provider, who will make this referral at a time it's necessary. One rule I've heard from an endocrinologist from before is if they're on several oral medications trying to control their blood sugar, or maybe recently had to be started on insulin, they could think about seeing an endocrinologist to help with that management. Dr. Do you have anything to add?
No, I think that all sounds, that's the same opinion that I have. I feel that endocrinology is a lot like podiatry, where the sooner the better many times. I think starting with your primary care is a great idea, and if your sugar, for example, is starting out like your hemoglobin A1C at 10 or 11, then I would definitely see endocrinology right from there, because, they specialize in getting your sugar down, and we need all the resources we can with things like this. So anytime that anyone is using insulin, really, I think endocrinology is a big help.
Thank you. And I just wanted to mention, through University of Maryland Charles Regional Medical Group, we have an endocrinology practice here in Waldorf, Dr. Sharon and Dr. Levy. So we'll be sharing that information for that group later in the presentation as well.
Great. And actually, while we're doing the Q&A, I don't know if we can put the splash screen up. That might be a great thing to have up right now, just so that people can see that and they can go ahead and jot down the number and have time to do so. Thank you. All right, so our next question is, do they perform glucose tolerance tests to diagnose diabetes? I think that's a great question. I don't know the answer.
So the test that I find as the truest test for diabetes would be the hemoglobin A1C. I think it was discussed earlier, and what that tells us is what does your sugar range over the course of 3 months. And it gives us a percentage of how much sugar is in our blood, essentially. And many practitioners have different rules of what is the diagnosis of diabetes, but I think the American Diabetes Association agrees that medication is needed at about 6.5%. So I don't know if Mary, if you want to elaborate on the glucose intolerance test.
So I believe that would be used more during diagnosing gestational diabetes, is when they would do that test to see how a woman's body during that course of being pregnant tolerates that glucose intake. That's been at least my experience from doing that a couple of times myself. So more so the hemoglobin A1C or that fasting blood glucose that I talked about earlier, those would be your more gold standard for using for a common diagnosis.
Mm-hmm. Okay, great. And anybody who asked a question, if we aren't completely answering that question or you have some follow-up questions, feel free to continue to post them in the Q&A. We'll continue to ask them and roll around to them again. Our next question is, I try to stay away from juices and fruits. Are there any okay, meaning better than other ones, to consume?
That's another great question. So I'm glad people are thinking about that. We always think of fruit as healthy, fruit and vegetables, the more the better. But when it comes to fruit and diabetes, you actually have to think about the fructose or the sugar that's made into that fruit that you get by ingesting it or drinking fruit juice. So my practice would be just definitely be watching your labels when it comes to juices and how much sugar. Some are made differently than others. Some are more natural. Some actually add sugar along with the fructose you're getting. I can't think of any specific ones that I would say are much better than others. What you want to do is watch your portion of what you're taking in and make sure you count that into your overall carbohydrate intake for that day. And that's what you would learn by coming into our diabetes education is how to count carbohydrates, what portion equals what for carbohydrates, how many should you eat in a day, that type of thing. But it's really good if people are thinking about their portion size when it comes to that. Dr. Cadieux, anything to add?
No, I agree. Juices in general tend to be very sugary. So I would say in your earliest diabetes diagnosis to really just avoid all juices. Fruit does also have sugar in it, but there is always pros and cons to fruit. So I would say, like, speaking to your primary care doctor or your diabetes specialist about what fruits you should or shouldn't be eating.
Okay. Yeah, Cindy, our diabetes educator, Cindy and Stephanie, they would tell you just stick to water or, unsweetened drinks if possible. Don't consume your calories and your carbs there when you could save it for yummy foods you could eat otherwise.
Mm-hmm. Really good advice. So the next question, actually, you guys have pretty much answered it, but there might be some other items in here that are, because it's kind of a follow-up question. Do I need to see an endocrinologist, or can I just manage my diabetes through my primary care doctor?
So if they're managing well, their blood sugars are in good control, they're not, sometimes people are able to start on medications and maybe come back off of them with lifestyle changes around what they're eating and the activity they're getting. Perhaps at that point, a primary care doctor would be able to help them manage. But if it's getting more complicated than that, like Dr. Cadieux and I both mentioned, you're on several medications now to manage it. Maybe your blood sugars are still consistently running high. You definitely should think about seeing an endocrinologist. They specialize in that management, so why not have their help in this battle that you're facing?
Great idea. All right. This is a good one, too. Does this is regional center. I think they're talking about the diabetes education center, I think, or just maybe as our hospital system in general. Do we offer exercise programs to assist with controlling diabetes? So in addition to diet, do we also offer exercise programs?
I love that question, Brianna, because we recently started something. We have a program called Cardiac and Pulmonary Rehab, where it's mostly patients coming in that have heart disease or lung disease, and they're monitored and they exercise, and there's a nurse and a respiratory therapist there. Well, now they've opened that up to phase 3, which means they don't wear a heart monitor, but they're still there using our equipment and being kind of managed by professionals, unlike a gym where you have someone there to respond right away if something happens. And they can come in and kind of pay for what's similar to a gym membership and exercise in our cardiopulmonary rehab center to get the advantages that exercise brings to managing your diabetes. So if they're interested in that, I would say call the number you see on your screen, the Diabetes Education, 301-609-5444. Lisa will usually answer the line, and she can connect you with Brian Laux to tell you more about that program.
Great. Hey, what great question. I love our audience. They're lovely.
Me too. What a great set of questions.
It is. Well, this next one I really like because this is a really good question. So why do my readings vary so much even when my carb intake only varies slightly? I can imagine that being pretty frustrating, so I would love to know the answer.
Well, a lot of things can influence it. Even if your carbohydrate intake is pretty steady, which carbohydrates you're taking in, whether you're taking in fiber along with those carbohydrates or protein, that's going to slow down, because with protein or more fiber, you have this nice steady blood sugar control with your carbohydrates. Without those things in your diet, you can have this quick spike. I love to talk with my hands. Quick spike up, and then these highs and lows that you don't want. So sometimes it's variable depending on the other foods you're taking in your diet with the carbohydrates that you're choosing. Also hormones. Pregnant women in particular, their hormones can really play into what's happening with their blood sugar. So that's something to take into your overall management as well. Dr. Cadieux, any other thoughts for why they'd be so
for your sugar? The sugar is difficult to control just in general, and there are many, many things, like you were saying, that affect it. Different medications can affect it. If you have some sort of illness like a cold or a fever, can also raise your blood sugar. We see blood sugar rises in any sort of stress immune response. So I would say in general, it's better to focus on trending your sugars down than one or two that are higher or abnormal compared to your usual. What I tell patients is a goal sugar in the morning around like 120 or 110 is good. And of course, in the evening, you'll notice it to be higher because you've been eating throughout the day and you just ate dinner. And that's okay. And, that's expected. And then I also just wanted to add about the last question, that the research shows that exercise is very helpful for diabetes. And even 30 minutes of like cardiovascular activity 3 times a week decreases all illnesses and what they call cause mortality, such as heart attack or poor blood flow, or all of these things by up to 60%. So exercise is actually one of the single most important factors in diabetes and just in general health. So.
Right.
And we always recommend, Brianna, before they start any exercise program, of course, talking to their primary care provider about their tolerance and being ready to do that and how safe it is for them. But
yeah, walking can be helpful. So.
Yeah. And you don't have to be like down to that. We talked about weight loss, even losing 10 or 15 pounds. You don't have to actually be down to what should consider like your ideal body weight. People that are overweight or obese can still be fit, and that can help their health so much. So people shouldn't wait necessarily to lose weight to start some of that.
Okay, great. This is probably a lot of the same things that you just answered will apply to this, but it might be something else in particular. And this person wants to know what they can do to lower their morning reading in particular. Is there anything different from in general, or is it the same?
I think that it would be a balance of what you're eating like late at night, not snacking or eating or drinking sugary drinks either late at night or during the night, and then any slight modifications needed with your primary care doctor or your endocrinologist to your medication. That would probably be my recommendation. I don't know if Mary has anything else to add on to that.
Yeah, that's a great thought. Where my mind actually went with it was actually talking to a dietitian as well about meal planning, because sometimes you do need that snack, but a healthy one, to Dr. Cadieux's point, late in the evening. That way you don't have a rebound high blood sugar because maybe you dropped low during the night and, your liver felt like you needed more sugar. Now all of a sudden in the morning you're quite high with that blood sugar. So sometimes you have to think about that bedtime snack of something healthy and talk to a dietitian about when you're taking in your carbs to kind of keep that more level and managed.
Right. Okay. I think, Dr. Cadieux, you probably already answered this one, but just I'll ask if there's anything you want to add to it. And the question was, should a diabetic routinely see a podiatrist? And I think you had said that they should see one routinely. Is there anything you want to add to that?
I would just say that it's sort of just built into your other appointments is what I tell patients. You see your primary care doctor every 3 or 6 or 12 months, depending what they feel is needed, and you see your dentist every 6 or 12 months, depending what is needed. And I feel that if you have diabetes, then you should also see me at some sort. It's typically every 3 months. Sometimes it's every 6 months, and sometimes the relationship is needed more or less. But we would work that out and discuss that and make sure we were both comfortable with it. So
that's good. We touched on this question a little bit, but I think getting into it a little bit more, somebody wants to know what is A1C and why is that important?
So it is a number that's determined by your blood work. It's typically ordered by your primary care physician. And what it means is how much sugar is literally in your blood over the course of 3 months. So because, as we've discussed, sugar does fluctuate for many causes, such as illness or diabetes or a stress response. So knowing where it lies for 3 months gives us a more true picture of what your body's doing. And that's essentially, I guess, why it's important, because it tells us how your diabetes is and how it's been over the course of time, as opposed to a fasting blood glucose level is what your sugar measures at that moment in time only. So I hope that helps.
Well, that is. That's good. I think that was a great description.
Sorry. I'll give some quick ranges for A1C levels. So normal would be considered below 5.7. Below 5.7. 5.7 to 6.4 is considered pre-diabetes, and 6.5 and above would be if you have diabetes.
Okay, great. We talked a lot about type 2. This question is about gestational diabetes. And the question is, does gestational diabetes affect the child during pregnancy? And is the child at high risk at any time during that pregnancy?
Do you want to answer this one, Mary? Or
Yes.
Okay.
So we have frequent visits to our diabetes education center for women that have gestational diabetes during their pregnancy, and it is, yes, because they're so high risk during that time, and it's so important, even more so than regular diabetes, to have a very strict control over their blood sugars. So working with their OBGYN, possibly an endocrinologist, and then their diabetes educator is going to be essential for a safe pregnancy for both that mother and their baby. Babies in general can tend to be larger in size, which can make for difficult deliveries as well if that blood sugar is not well managed. So very crucial. Many of the patients that Cindy or Stephanie, our diabetes educators, work with will even send in their glucose logs daily, weekly, to be looked at to just make sure they're maintaining that tight control. So very essential.
Very good. Next question actually is written two different ways. And so one of them is, if my sugar is high 150 and above at bedtime, should I eat a snack before bed? And then there's a revised question, or if it's 125. So I guess if it's basically, if the sugar is high at night, should they eat a snack before bed?
So if your sugar is high, I would not recommend eating a snack necessarily. I would prefer that you probably didn't eat a snack before bed. If you are, really hungry and feeling that you want something to eat, then it would be probably best to discuss that with like a dietitian or with the diabetes education of what is an appropriate snack to eat before bed. I think maybe, I don't know if this question is coming from the concerns of low blood sugar. So there are times when with diabetes, your sugar can get too low, which is also a problem, and then eating a snack is a good idea. But that's usually when your sugar is, below 80 and when you're not feeling good. When your sugar is high, like 120 to 150, and if you're not hungry, I would definitely say don't eat a snack.
Right.
So
I agree. I mean, that needs to be very individualized depending on the medications that they're on as well. And that would be the type of situation you would sit with your doctor or the diabetes education specialist and discuss that type of thing. That way they can look at your big picture around what are you normally eating, what times would you have taken your blood sugar, what times do you take medication, and what are you on. So very hard to speak to something like that without really individualizing the answer.
Right. I'm sure there's a lot of different extenuating circumstances around each individual person. So that's great advice. I did have one more question on Mary. Just if you could repeat the A1C levels somebody would like to jot those down, and so if you could just repeat them one more time.
So normal is below 5.7. Prediabetes is 5.7 to 6.4, and 6.5 and above would be considered the range of having diabetes. And again, there are 3-month look at how your blood sugar's been running. So not something you can all of a sudden eat healthy for a day or two and go see your doctor and have fixed it to where you're going to have really good results.
Not like college, where you can do a crash study beforehand.
Right.
The only other thing I would add to that is for podiatry, we see more complications when you're at a 7 or above. And that's for other things too. Diabetes affects your kidneys and affects your eyes, and it affects your whole body. And so you always want it to be lower, the lower the better, but really around 7 is a good goal also, to keep all the other complications at bay.
Okay. Mary, could you also, after the webinar is done, if you could post those levels in the comments, I think that might be helpful to people too. So going back, this is kind of following that same line. We had talked about if somebody's blood sugar is too low, what is the best food they can take quickly to help them with that?
So this, again, is something I'd rather individualize with that person, but there are glucose tablets you can use. You can buy at any pharmacy to get your blood sugar up quickly. Oftentimes, Cindy or Stephanie or educators would probably tell them to have something relatively sugary with them, maybe some juice or some candy that can get it up quickly as well. But what you don't want to do is consume so much it shoots up, but then can drop right back off. You also want to get something to stabilize that blood sugar and keep it up at that normal range. So eating something besides that candy or taking in the juice would be important. Dr.
Okay.
Cadiuex, what do you think?
Yeah, I agree. I think if you're feeling really sick, then something, I guess, sugary is best at that moment, but discussing that with your primary care or your endocrinologist and really limiting those fluctuations long-term is important.
And I think that's, this next question actually goes to play with that, and that, the question is, why do glucose readings vary so much between glucose monitors? And that might be part of the problem, the monitors, not the actual sugar.
So yeah, there can be variation. What we always do is try to research the most reliable glucose monitors, and that's what we set our patients up with. Of course, part of it's what's affordable as well. It's not the monitor itself that's expensive, but it's all the supplies that go with it for actually pricking the finger and the strips for testing one. And so kind of an individual decision which meter or what their insurance will cover, but there is variability with the readings. So it's always best to also be watching for the signs and symptoms of hypoglycemia or low blood sugar, feeling dizzy, not feeling well, just overly tired, blurred vision, many things that should quickly step out to you and say, maybe my sugar's low. Especially, try to correlate it to the reading that you're seeing, but if you're feeling these symptoms, sometimes it's safer to go ahead and react and treat it like you're having hypoglycemia than to not do anything, because hypoglycemia is definitely a state of emergency with your health if it gets too low.
The next question is, does caffeine elevate blood sugar?
Dr. Cadiuex, any thoughts?
I don't think that there's any indication that caffeine itself elevates blood sugar, but caffeine does tend to be in sugary drinks like Coke and, coffee with added sugar. Mountain Dew has a crazy amount of sugar in it. So caffeine itself in like black coffee, as far as I know, is reasonable, but it does pair with sugar. So.
Even Gatorade, that always surprised me, but there's a lot of sugar in Gatorade, and sometimes people are sick or exercising, they think they need to drink this Gatorade, and they really have to watch the sugar that's in it.
All right. I love our last question. This is our last one. And by the way, thank you, everybody, for all your great questions. These have been really great questions. Okay. I'll get 2 more. I'm going to ask this last one, and then we'll do 1 more. So what's the best milk to use? Let me just pop that one up. I'm going to squeeze that one in real quick.
I'm sorry, the best milk to use, is that what you said?
Yeah, and I think probably what they're referring to is probably dairy milk, almond milk, coconut milk. I mean, all the things that aren't, milk-type products.
So they really vary in carbohydrates depending on which one you're getting. There's skim, there's 1%, 2%, whole milk, silk, all the almond milks, things like that. What I would say the best thing to do is compare your serving size with the carbohydrates. You have plenty of time to do that in a grocery store. Look at your labels and compare them. And the one with the lower carbohydrates with equivalent serving sizes is going to be that better one for you to drink.
All right. Well, now I'm going to really get to my last question, and it's the one that I think is pretty important. We actually had discussed this before, was can you actually be cured from diabetes, and in particular type 2 diabetes?
That is a great question. I forgot to say earlier, because I described type 1, meaning the pancreas produces no insulin, and so you have to take insulin to survive. Type 2 is when you either stop producing as much insulin or it doesn't work as well as it once did to open up those cells and let the sugar in. So type 1, yeah, definitely you're going to remain on that treatment. You're not going to cure it, at least right now. They don't have a cure. Type 2, many unreputable sites on the internet would lead you to believe that they can cure type 2, and they would gladly sell you something to help do so. But the fact remains that it's really not a condition that they say they have a cure to at this time. However, with dietary modifications, being on the right medications, increased activity, it can be controlled, even to the point where people, like I said, can come off of medications maybe they've had to start at one point or another to manage it. So it's more so like remission and managing it than curing it altogether. Any other thoughts, Dr. Cadiuex?
No, I think that's exactly what I was going to say. Exercise and, diet change and weight loss has been shown to lower your hemoglobin A1C, and it can be lowered to the point where you don't have any of the complications, and you don't need to take insulin, and you'll have a lot of your medications modified or changed, but there's no true cure for diabetes. So.
Great. Well, thank you both for all of your time, your education, your expertise, and all of your care for our community. It's very much appreciated by myself and all the people that I love in Charles County. So I just want to close with, if you know, or if you or someone you know and love thinks that they might be at risk for diabetes, call our Diabetes Education Center. The numbers are listed right here on our screen, and schedule an appointment. If you have prediabetes or type 2 diabetes, you can also join us for our bi-monthly diabetes support groups. So thank you for joining us today.